Very good afternoon, everyone. On behalf of Ankura Hospital for Women and Children, I welcome you all. Today we have speaker Dr. K.L Poornima. She is well-known gynecologist and obstetrician in Hyderabad. Further, the whole session will be moderated by Dr. K. Jayashree. She is consultant gynecologist and obstetrician at Ankura Hospital. Ma'am, the session is over to you.
Good afternoon and welcome everyone. I am Dr. Jayashree, gynecologist working at Ankura Hospital, Boduppal. It's my pleasure to introduce you Dr. K.L Poornima. She is quite an experienced obstetrician and gynecologist with an experience of 20 years. She did her MBBS, DGO and DNB from Gandhi Medical College. She specializes in dealing with high-risk pregnancies and is an episionologist. She is very compassionate towards her patients and her friendly attitudes makes her very approachable. Without further ado, I hand over to Dr. K.L Poornima to speak about anemia and pregnancy. Ma'am?
Good afternoon, everyone. I welcome you all for this webinar. And today I'm going to speak about anemia in pregnancy. Just 1 minute. The slides. I'm sorry, the slides. Slides move over to. Just a minute. Yeah, so sorry for the delay, slight delay. So today I'll be speaking to you about anemia in pregnancy. So when we are talking about anemia, so this anemia is the commonest medical disorder in pregnancy, and the prevalence in India varies between 50 to 70%. And of these, there are many types of anemia, but the nutritional anemia, that is the iron deficiency anemia, is the commonest one. So I will be mostly talking about the commonest, that is the iron deficiency anemia. And one more reason why we are going to talk about anemia today is it's very relevant because it is a very important contributor to maternal and perinatal morbidity and mortality, both as a direct and or as a indirect cause. So first, let's see what, the definition of anemia. So anemia can be defined as a condition where the circulating levels of the hemoglobin are quantitatively, hello? Anemia is a condition, anemia is a condition where circulating levels of the hemoglobin are quantitatively or qualitatively lower than normal. So in non-pregnant women, hemoglobin less than 12 grams per cent is taken as anemia, whereas for pregnant women, the WHO criteria is slightly different. Hemoglobin less than 11 grams per cent and a hematocrit less than 33% is defined as anemia. And the CDC gives a different criteria based on the trimester also. So hemoglobin less than 11 grams for the first and third trimester is taken as anemia. And in second trimester, hemoglobin less than 10.5 grams is considered anemia. And based on the severity of the anemia. So anything less than 10 or 11 is taken as anemia, but to grade the anemia mild, moderate or severe, the ICMR grading is mild anemia is 10 to 10.9, moderate is 7 to 9.9, and severe is less than 7 grams per deciliter. So this grading is required to know how we are going to deal with it, what is the treatment option that we are going to adopt to treat this anemia. Then why are we talking about anemia? How is it relevant as far as pregnancy is concerned? Because anemia is a serious problem, especially in pregnancy. First, we need to understand this so that we will know why we have to really treat it and treat it really aggressively. So anemia, if the mother is anemic, the pregnant mother with a low hemoglobin, she is at a very high risk to give birth to a low birth weight baby. This low birth weight baby can either not survive, and this will again contribute to the infant mortality rate, or even if the baby survives, it is more prone to diseases there is a poor mental development, there can be poor physical development and disability. So, and on top of it, once this child grows up, and if child is a girl, she will again grow up to become a anemic mother, and this whole cycle repeats. So this is the reason we really have to understand anemia and treat it well in pregnancy. So before going into the details of anemia and the different types and how we treat it, I want to add a note about this physiological anemia in pregnancy. This physiological anemia in pregnancy is a normal phenomenon which occurs in all pregnant women. So what is the criteria to define physiological anemia of pregnancy? In physiological anemia of pregnancy, there is plasma volume increase of 40 to 50%. The RBC mass increases by 30%. So this physiological anemia of pregnancy can be explained due to the discrepancy in the increase in the plasma volume and RBC mass. So the plasma volume increase is much more than the RBC mass increase. So as a result, there is a drop of hemoglobin concentration by 2 grams per deciliter. And this is due to the hemodilution. So to define physiological anemia, the hemoglobin level of 10 grams per cent, the RBC count is 3.2 million cells per cubic millimeter. The packed cell volume is 32%, and the peripheral smear is of normal morphology, that is normocytic and normochromic. We will also see, now I will talk about the prevalence of anemia. From this graph, we can see that worldwide also, anemia is very prevalent, more so in the preschool children, in pregnant women as much as 42%, and in non-pregnant women of the childbearing age also, it is as much as 30%. So we need to deal with this problem right from the childhood through the childbearing age and during pregnancy also. This bar diagram is showing the percentages of women suffering from anemia and the severity. So the normal is only 10%, whereas mild anemia is present in as much as 36% of the women, and 50% of the women who show moderate anemia. So this is also another indicator to tell us that we should definitely know about anemia and treat it well. Coming to the causes of anemia. So how do we classify causes of anemia? Causes of anemia can be etiological, we can classify as etiological classification and morphological classification. In etiological classification, this can be defined as inefficient erythropoiesis, as in nutritional anemia like due to deficiency of iron, B12 and folate, and or due to blood loss anemia, like as it is seen in chronic blood loss due to parasitic infections like foam and malaria, and acute blood loss due to APH and PPH. And last would be where there is increased destruction of RBC, like the conditions that we most commonly encounter, hemolytic anemia in PIH, where in severe cases it can lead to HELP syndrome, or hemoglobinopathies like thalassemia, sickle cell anemia. Aplastic anemia, where there is absent erythropoiesis, is quite rare. So these are the main causes for anemia, and we can also the types of anemia can be like based on morphology, like microcytic or macrocytic or normocytic or dimorphic. So there are so many different types of anemias, but the most commonest one and the one that is very relevant for us in our clinical practice, it is the iron deficiency anemia or the nutritional anemia. So my further talk would be on basically on iron deficiency anemias. So let's see the prevalence of this iron deficiency anemia in India. So it is quite prevalent in India due to some reasons. Basically, first, our dietary intake of iron is quite very less, and the intake also, because of the poor bioavailability because there is very high phytate content in Indian diets. So this inhibits the absorption of the available iron also. And some diseases like malaria and hookworm are quite very common in our country. So this also leads to chronic blood loss and leads to anemia. Coming to the pathophysiology of nutritional anemia in pregnancy, already we have seen previously that the diet is deficient and whatever iron is available is also not being absorbed. So in pregnancy, once the woman starts, already she's anemic, and once she becomes pregnant, these are the other factors that are going to increase the severity of the anemia. So what are these? There is augmented erythropoiesis in pregnancy. There is increase in blood volume almost as much as 40 to 45%. And this increase in plasma is more than the red cell mass like we have seen previously. So this leads to hemodilution. And with repeated pregnancies and frequent pregnancies with small gaps between the pregnancies, the iron stores are also depleted. So all these things will result in iron deficiency anemia. Coming to the iron requirements and losses during pregnancy. So we need to know what is a requirement and what are the losses during pregnancy so that we can treat anemia in pregnancy. So during pregnancy, a total of around 800 to 1000 milligrams extra iron is required. And of the total 1000 milligrams that is required, 300 to 50 milligrams, 300 milligrams is for the fetus and 50 milligrams is for the placenta. And we can attribute 400 to 500 milligrams for the increase in red cell mass. And 250 milligrams iron is lost during delivery, that is in the form of blood loss. And 220 milligrams are basal losses. And these are the total iron requirements. And what happens due to cessation of menses and contraction of the blood volume after delivery, conservation of iron is around 400 milligrams. So iron parameters during pregnancy, we can see this graph. This graph is showing us that during the first and second trimester, the serum iron and ferritin levels decrease drastically. And there is also a deficiency in the maternal iron storage, which results in deficiency of the neonatal iron storage also. Here, I want to add a few words about the latest recent advances in iron absorption, and they have talked about this hepcidin. So let me tell a few words about hepcidin. What is hepcidin? Hepcidin is an iron regulatory protein. It is produced by the liver. And how does hepcidin act? This hepcidin blocks the ferroportin channels and reduces the iron level in the blood. So what we need to understand is this hepcidin is an iron regulatory protein and it is produced in the liver and it blocks the reduces the iron level in the blood mainly by controlling the enterocytes, the macrophages and hepatocytes. So there are many conditions in pregnancy which have been shown to increase the levels of hepcidin, especially the inflammatory states. So these conditions, when are present in pregnancy, tend to increase the hepcidin levels, and then obviously again the iron levels are going to drop. So these inflammatory states are obesity, impaired glucose tolerance, diabetes, including the gestational diabetes mellitus, preeclampsia, and infections like malaria. So whatever is the iron available also is not absorbed, and it further increases the severity of the anemia. And there is a clinical study which has reported 6-fold higher serum hepcidin levels in pregnancy. So And then a few words about consequences of higher hepcidin during pregnancy. So higher hepcidin levels have been shown to increase the risk of preterm delivery, intrauterine growth restrictions, preeclampsia, and gestational hypertension. So this is a graph which is showing the required daily allowance of iron through before pregnancy in the first trimester, second and third. So from this graph, it is very obvious that the iron requirements keep on increasing in the pregnancy and their maximum in the third trimester. So this is the daily requirement. Normal diet contains around 14 milligrams of iron, but the absorption of iron is very, very less, almost only 5 to 10%, and it is even more less in the vegetarian diet. So an additional daily iron demand of in early pregnancy is only 2 to 3 milligrams, which can increase to as much as 6 to 7 milligrams per day in the later pregnancy or in the third trimester. So it is very obvious to us from these data and the graphs that we have seen previously that only diet alone cannot sustain the requirements of iron requirements for the pregnancy. So a daily supplement of 40 to 60 milligrams of elemental iron is required during pregnancy. And along with it, folic acid is also required in the dose of around 400 to 600 micrograms per day. Vitamin B12 is also very important. Coming to the symptoms of anemia. So a lot of the symptoms of anemia are present in normal pregnant woman also. Even a normal pregnant woman would feel fatigue, weakness, and there can be loss of appetite. But once anemia is also present in pregnancy, all these symptoms can be aggravated, and it can lead to a lot of complications. So we need to detect anemia early and treat it as early as possible so that we will avoid all the complications. In severe cases, in severe anemias, patient can have palpitations, dyspnea on exertion, swelling. On physical examination, varying degrees of pallor we can see. There is glossitis, stomatitis, and in severe cases like severe cases, or if the patient is in CCM, as much as increased JVP, tachycardia, tachypnea, and postural hypertension can be seen. So once we have seen the what is the symptoms and signs of anemia, now how is this anemia going to affect pregnancy? We need to understand that also. So in the mother, how is anemia going to affect the pregnancy? So an anemic mother during the antenatal period, she is at a higher risk to develop preeclampsia, infections, heart failure, and preterm labor. And during labor in the intrapartum stage also, the patient can go into uterine inertia, postpartum hemorrhage, cardiac failure, and shock in severe cases. And puerperium, the patient is at very high risk for puerperal sepsis, subinvolution, failure of lactation, DVT, that is puerperal venous thrombosis, and pulmonary embolism also. And the effect of the pregnancy on anemia is like we have discussed previously, a mildly anemic patient, because of the physiological hemodilution, will progress to marked anemia, and the patient who is severely anemic becomes very symptomatic by the end of the second trimester. And to look at the effect of the anemia on the fetus and neonates. So in the babies of anemic mothers, they show the mothers are at a higher risk for abortions, preterm births, intrauterine growth restrictions. It can even result in intrauterine death. And there is a very high incidence of low Apgar at birth. The neonate may be more susceptible for anemia and infections. Further, because the mother herself has very low stores of iron, these are not transmitted to the neonate, and so the Neonate also has very low iron stores. There is higher perinatal morbidity and mortality, and the cognitive and affective dysfunction is also seen in the neonate. A word about the most critical periods in the pregnancy. Uh, so there are certain periods in the pregnancy when the mother is at a very high risk if she is anemic. So this is the 28 to 30 weeks of pregnancy when there is maximum plasma volume expansion, and in labor. In labor, because due to the uterine contractions, as much as 300 to 400 ml of blood is returned from the uterus into the venous return, and that increases the cardiac output by almost 30%, and so there is a lot of load on the heart. And along with it, there is maternal pain, anxiety, and valsalva maneuver. All these in labor are going to put an extra burden on the heart. So these are the very risky periods for the pregnant woman with anemia. And immediately after delivery also, there is an auto transfusion of almost 500 ml of blood is returned to the venous return, and the cardiac output increases, which again puts a load on the heart. So immediately after delivery, the stroke volume, the heart rate, and cardiac output increase within 10 minutes and stay up to 1 hour. So this 1 hour after delivery is also very, very risky for the mother. And early puerperium also, the mother is at risk for infections and the deep vein thrombosis. In severe patients who have not been treated properly, they can even go into the congestive heart failures. So we have seen the symptoms, signs, and also all the problems that can occur with an anemic patient. So how do we go about what is a workup for a pregnant woman with anemia? First, we should take a detailed history, the age, the parity, because multiparous women are at more risk. Then the diet, is she vegetarian? Or what is the specific diet? We need to spend time with the patient, counseling her about the diet. So it is very easy to sit in the OPD and write tablets, iron tablets, and ask her to go. But when it is anemia is so prevalent, I feel we should spend some time counseling the patient, asking her really what she's eating at home. She might be thinking that she is eating a very healthy diet, but they are not aware. So we should counsel them and tell them and inform them about the kind of diet that she needs to take. And then we have to take a previous history of chronic bleeding, worm infestations, or malaria. On examination, we should look for pallor, glossitis, and in severe cases, all these signs can be present. In the investigation part, once we start workup and do all the tests, first thing to know the severity of anemia, we have to do the hemoglobin. And all the guidelines are suggest that we should do a hemoglobin at the first visit, repeat again at around 28 to 30 weeks, and again at 36 weeks. And this is fixed. We can, and for some patients, we may have to do it more frequently also, depending on the case. To know the type of anemia, we will have to look at the blood picture. So whether it is microcytic, macrocytic, or dimorphic picture. So looking at the blood picture, we will know what type of anemia she's having, and we will deal accordingly. Bone marrow activity and reticulocyte counts are also done, but rarely. In very severe cases, we will have to do. And when do we go for this bone marrow is when we are suspecting hemolytic anemia or the iron deficiency anemia. To know the response to treatment, we can do these tests. The cause of anemia is, to know the cause of anemia, we will have to do the other investigations, which I will be talking about. The most important investigation for us in an anemic patient would be the complete blood picture. What I would like to say a few more words about this complete blood picture is, even today, a lot of gynecologists or obstetricians would just do the hemoglobin. I feel we should abandon that procedure. More information than just the hemoglobin itself. So a normal smear is normocytic, normochromic. That is the normal size of RBC with normal color of RBCs. Whereas in iron deficiency, we can see a microcytic picture with hyperchromia and anisocytosis. And in the smear, we can even detect the malarial parasites if there is malarial infections. And very rarely we see aplastic anemia, where there is pancytopenia can be seen. And in cases where we are suspecting sickle cells also can be demonstrated on the smear. Next is investigations in the iron deficiency anemia is the red cell indices. These include the RBC count, PAP cell volume, mean corpuscular volume, and MCH and MCHC. All these things are decreased. All the values are decreased in iron deficiency anemia. There are some special investigations which we will do to know the iron stores. So these are the serum ferritin levels, serum iron binding capacity, and the percentage saturation of transferrin. A note on because we are dealing mainly with iron deficiency anemia, we also should know about the other conditions where there will be microcytic anemia. Because in iron deficiency anemia, we have a microcytic picture. There are some other conditions also which show a microcytic picture. So we need to know how to differentiate that. So here the other thing that we see with the microcytic picture is thalassemias. So here we can see that all the indices are reduced even in thalassemia. But notably, we can see that the serum iron and serum ferritin are reduced in iron deficiency anemia, but they are normal in thalassemia patients. So supplementing them with iron is not at all going to be helpful, and in fact, it can be harmful. So this is how we can differentiate between iron deficiency anemias and thalassemias. So we should note this point. The other investigations that can be done are urine examination to look for RBCs and CAS to know if the patient is having any urine infection. Stool examination for occult blood and ova. Bone marrow examination is done very rarely and it's only suggested for refractory anemias. Then serum creatinine to rule out the renal disease and to know the kidney function. And hemoglobin electrophoresis also is done to really know to rule out any thalassemias that can be present. In our a lot of institutions do hemoglobin electrophoresis regularly, routinely for all the antenatal patients. That can be done when it is not feasible. We can at least do for all severe cases, hemoglobin electrophoresis should be suggested. Then coming to the management, here in management, our aim in management is first to bring the hemoglobin level to normal by the end of pregnancy and to restore the iron stores. That would be our aim. And how do we go about? What are the options that we are going to take in treating this would depend on the severity of anemia, the gestational age, and the comorbidities that are present. That is how we will manage a case of anemia. So under the management, the first would be the prevention or the prophylaxis, then the nutritional management, and in medical management, we have oral iron therapy, parenteral iron, then blood transfusion, and management of pregnancy in all the three phases, that is during the first, second, and third trimesters, during labor, postpartum, and contraception. So the first thing would be in the treatment would be the improving the diet. So we need to improve the diet educate them about the iron-rich foods, tell them what to avoid, what kind of food to take. So that is how we will improve her diet so that the absorption of iron is improved. Then any infections, which like worm infestations and all, if detected, have to be treated. Food fortification with iron and folic acid is also being done as a prophylaxis to prevent iron deficiency anemia. So these are the iron-rich foods. So we should spend some time and educate the woman about these iron-rich foods that she needs to take daily, so that she will not develop anemia, or even if she develops anemia, she's going to improve. These are the foods that we should suggest. Coming to the prophylaxis, the WHO has recommended prophylaxis of at least 60 milligrams of elemental iron plus 400 micrograms of folic acid per day for at least 6 months. Out of the 9 months, at least 6 months and 3 months postpartum. Whereas in our Indian scenario, our National Nutritional Anemia Control Program of India suggests 60 milligrams of elemental iron plus 500 micrograms of folic acid, and at least for 100 days in the second trimester. This is all prophylaxis. So there are various government initiatives of our Indian government, like the Iron Initiative, National Iron Plus Initiative, Anemia Mukt Bharat. Then we have the Poshan Abhiyan, and also there is 12 by 12 initiative. This 12 by 12 initiative was launched by the WHO, UNICEF, and FOXI also. That is, at least by this program aims at achieving at least a hemoglobin of 12 by the time the girl is 12 years old. And once if they detect that the hemoglobin is less, then treat it aggressively, so that by the time the girl grows up and she becomes pregnant, she is having adequate hemoglobin levels. These are the various government programs that are being taken up. So iron supplements can be given. There are various salts. The commonest ones that we use are the ferrous fumarate and ferrous sulfate. There are other various salts also that are available in the market. So iron supplementation in pregnancy. So for whom do we, so like previously I have explained, 60 milligrams of elemental iron and 400 micrograms of folic acid daily during pregnancy and 3 months after also. This 3 months postpartum is for the restoring the iron stores. But this is prophylaxis. But in a patient with anemia, the therapeutic doses are higher. That is around 180 to 200 milligrams per day in divided doses. And the way we prescribe iron, and especially when we are advising higher doses of iron, we need to tell the patient like to start slowly, like alternate day, then slowly increase it to daily 1 and then daily 2. That is how, otherwise there is going to be a lot of side effects and there might be a problem of compliance. And iron supplementation usually is not recommended in the first trimester. After the first trimester, we can start the iron. So, like in the beginning, I had told, while managing a case of anemia, we also have to see the gestational age, the severity of anemia, and the comorbid conditions. And depending on that, we have to decide whether we are going for oral iron, parenteral iron, or blood transfusion. So, for whom will we suggest oral iron? Oral iron is for moderate cases. That is, the hemoglobin is 8 to 11 grams and it is early in pregnancy. For them, we can suggest oral iron. Like I previously said, the oral, when we are suggesting oral iron, the food also we should educate them about the iron-rich foods and to avoid foods that contain high phytates should be avoided when she's taking the iron tablet. Vitamin C tablets are also good because they will increase the absorption of the iron that we are giving them. Certain contraindications are there for oral iron therapy, like intolerance to iron. A lot of women cannot tolerate oral iron, and then we'll have to look for the other options. And when there is severe anemia in advanced pregnancy, there is oral iron cannot be of any help to us. And then when the patient is not responding, what is the reason for no response? We are giving her oral iron, but still she's not responding. So what are the various reasons? One could be our inaccurate diagnosis. So the workup is very important. Like I said, we should not, the workup should be complete and the diagnosis should be complete so that whatever treatment we are giving, it will be effective. So inaccurate diagnosis, faulty absorption, and in spite of supplementing, if she is continuously bleeding, again she will not respond. And we should also rule out coexisting infections because if the infection is continuing, again she will not improve. Concomitant folate deficiency is also very, very common. That is why most of our iron tablets also contain folic acid. So because giving only iron is not going to help, even folate has to be given. So then next, what are the indicators of response to the therapy? First, the feeling of well-being, the patient is going to feel better and there is a better appetite. With oral iron, there is a rise of hemoglobin around it starts within 3 weeks. So it takes around 3 weeks for the hemoglobin level to rise. And reticulocytosis is seen within 7 to 10 days. This is again a recent advance or recently a new molecule has been introduced. So I want to say a few words. The iron sulfate, iron fumarate, all these are the older salts that we have been using, carbonyl irons and all. But the latest, they have introduced this sucrosomal iron, which is a new generation iron. I want to tell a few words about this. It is a new generation iron, and this sucrosomal iron bypasses the normal intestinal mechanism of iron absorption. So, and hence it ensures a higher absorption and bioavailability. So, what is this sucrosomal iron? We will see. So, it has been shown that it has higher absorption, it is better tolerated, there is much better compliance. So, this sucrosomal iron is a phospholipid containing carrier. Sorry. So we can see here this sucrosomal iron has a phospholipid bilayer, and in the center there is iron pyrophosphate, which has a high affinity to transferrin, and it also has tricalcium phosphate, which will improve its stability. And outer layer is a sucrester, which is which has gastro-resistant properties. So it will not have any side effects also. So this is the latest molecule that is there, and they are recommending this because it seems to be very good in absorption. So, and it has been shown that this sucrosomal iron is absorbed directly in 3 absorption pathways: the transcellular route, paracellular route, and M cells. That is, it is not only one way. It is entering the body in 3 different routes. So, it is highly effective. And like this study has shown that sucrosomal iron is more stable. So it is not degraded, and so the side effects are also less. So this is all about, we have talked about the oral iron therapy, how we will give, and how long we will give, how long it takes for a better response. Coming to the parenteral iron therapy. Parenteral iron therapy is when the hemoglobin levels are less than 8 and she is in the mid trimester, when we don't have much time, parenteral iron has to be advocated. Nowadays, we are using iron sucrose for parenteral use, and the dose of the iron sucrose is calculated by this formula, and the response is quite fast. It is almost 1 gram per week. So, parenteral iron is also very, very effective in in moderate to severe cases, and also when we don't have much time before the delivery, we can definitely go for parenteral iron transfusions. And coming to the last one, the indications for blood transfusion. So we should never, as far as possible, avoid blood transfusions. So we should never land in a situation where we have to give a blood transfusion. But sometimes we do have to give and we cannot avoid. So that is the whole idea of doing antenatal checkups and a CVP at the first visit, so that we detect it early and we can treat it early. But sometimes we have to give. So what are the indications of for the blood transfusion? So indications are when there is severe anemia and we are just seeing her at 36 weeks of pregnancy, then we have to give. And when there is acute blood loss, like in APH and PPH, then also the acute blood loss should be immediately replaced with blood. Then when there is a patient is not responding to oral or parenteral therapy, rarely this happens, then also we may have to give a blood transfusion. And in severe anemic patients, when they are becoming symptomatic or they are danger of going into a heart failure, we have to give her a blood transfusion. Coming to the management in labor. This labor has to be supervised, and it has to be done in a very, very intensive care unit, because if the patient is mildly anemic, it is all right, but severe anemic patient and all, the labor should be supervised, and there is proper counseling and consent should be taken, because she can have any number of problems during the labor. Like I said, due to the uterine contractions, the uterus will pump almost 300 to 400 ml of blood into the blood, and the venous return increases. So all these, there's a load on the heart. So this is a risky period, anemic mother in labor. So we need to counsel them, consent taken, and blood should be kept cross-matched. Nowadays, we are not using whole blood. It is only packed cells that have to be matched and kept ready. Then woman should be nursed in the propped up position, and the intermittent oxygen whenever required should be given. Precaution to prevent infection and blood loss should be taken carefully. Strict asepsis, again to prevent infections. Then prophylactic antibiotic can be given. Excessive use of IV fluid should be avoided. We need a line, but in anemic patients, we cannot overload them. And in decompensated patients, if required, we have to give a diuretic. But in decompensated patients and all, have to be treated in an ICU, not normal labor rooms. Coming to the second stage and third stage of labor, the second stage has to be cut short by forceps or ventouse. Like I told you, again, the Valsalva maneuver, the pain, the anxiety, and all these will increase the load on the pregnant mother's heart. There is going to be increased cardiac output. So to cut short it, we have to cut short the second stage with either forceps or ventouse. We should go for the active management of third stage of labor in the form of oxytocin and parenteral misoprostols. Usually we give 600 micrograms per rectum, and then 10 units of syntocinon IM immediately after delivery, and IV syntocinon, so that all these things are done to prevent any excessive blood loss. This mother cannot tolerate excessive blood loss. So active management of third stage is very, very important. Coming to the Lastly, the postnatal care and contraception. So early ovulation is encouraged because again, like we have discussed previously, in the postpartum period, an anemic mother is at more risk for the venous thrombosis. So early ovulation is encouraged. Hematinic should be continued for 3 to 6 months for her because we have to replenish her iron stores. We have to watch for subinvolution, puerperal sepsis, congestive heart failure, thromboembolism, and lactation failure. So once she is delivered, we are not safe. We have to watch her carefully because she can land into all these problems. And she should be advised to avoid pregnancy for at least 2 years, spacing, so that the child improves and also the mother will improve her hemoglobin and the iron stores are replenished. She should be advised either barrier contraception or IUCD also. And if she's multiparous, we can suggest a permanent sterilization method. So from this discussion, we can come to a conclusion that anemia is a very common, very relevant condition that we see in our day-to-day practice. Even in not in previously, like we thought in low socioeconomic women that anemia is more common. Even the software people or the educated women also, we see quite a lot of people with anemia. So we need to treat anemia, detect it, treat it, and prevent it so that we can have a good, healthy child. And future mothers are also will be healthy. With this, I thank you all for your patient hearing. Thank you.
Thank you, madam, for giving an excellent coverage on anemia and pregnancy for your valuable time. Thank you, Ankura Hospitals, for hosting this webinar. Thank you.
Yeah, so participants, delegates, if you have any question, you can ask in the chat box. Yeah, so far, I think all the queries are answered through this presentation, I think, ma'am. Yes, so thank you, ma'am, for the excellent presentation and for our speaker for the day. Thank you, Dr. Jayashree, for moderating the session elegantly. And Ankura Hospital for Women and Children, thank you all delegates for your valuable time. Have a nice day.